In the previous lecture, we began to talk about medical emergencies in the dental office, and we found that not only do dental emergencies happen only in the treatment area or in the dental chair, it can happen in the reception area, both before the appointment when the patient is stressed about what's going to be happening, or after the appointment when the patient's stress has been relieved and they can begin to relax and their body may go into shutdown phase. Or it can even happen after the patient leaves. So we need to monitor our patients to make sure both that they're good to go when they leave and also to make sure that they're feeling well before they get out of the dental chair. Specifically in this lecture, we're going to look at why is the dental patient unconscious. So it may be that the patient becomes unconscious or we find them unconscious, but we need to know why and what we can do about it. Possible causes for unconsciousness in the dental office can include hypoglycemia. Hypoglycemia means low blood sugar, and we know low because of the word hypo, and glycemia we know means sugar. So it's a low blood sugar. If we see hyperglycemia, we know that that they have high blood sugar because the word hyper plus glycemia means high blood sugar. Below that, we may see an acute allergic reaction if the patient has gone into anaphylactic shock, is unable to breathe. They may actually lose consciousness. A myocardial infarction is a heart attack. If the patient has had a heart attack, they could be unconscious or lose consciousness in the chair. Stroke victims will lose consciousness, and then hyperventilation. So again, we see hyper means overventilating, which means they are breathing too much or too fast. So when a patient hyperventilates, they have an inaccurate exchange of gases. So remember, when we exhale carbon dioxide. When we inhale oxygen. So if we are overventilating and we are breathing out too quickly, breathing in, breathing out too quickly, the gas exchange is not appropriate, and so we can lose consciousness because of that. So we may not have enough oxygen and too much CO2, or vice versa. We've learned already that the number one cause for a medical emergency in the dental office is stress. And by reducing stress, we also reduce the number one chance for a medical emergency. Beyond that, if a patient has impaired physical status, they are at a higher risk of having a medical emergency or becoming unconscious in the office. So an impaired patient may be a person who has a higher level of ASA risk. So if you remember our ASA chart, when we looked at patients and they're different, and how, if they have health considerations, if they're able to walk up a flight of stairs, that chart that we looked at in our first slideshow about medical emergencies, that would be taken into consideration when we think about impaired physical statuses. So often hand in hand with impaired physical status, you may have somebody who is compromised in other ways and is more likely to face an emergency in the dental office, including unconsciousness. If a patient comes into the office and has taken some type of a medication that we did not prescribe before they came to the appointment, and it could be alcohol or other drugs, if we don't know about them and we prescribe other drugs, there could be interactions, or the drugs that they took could cause a reaction, including unconsciousness in the dental office. So we always want to make sure that we review every possibility when we go through the medical history before we start treating a patient. In the dental office, some of the medications that we often give to our patients, including opioids, non-opioids, local anesthetics, anti-anxiety medications, all of which are analgesics, can alter the level of a patient's consciousness. So these are some of the common drugs used in dentistry that may also play a part in medical emergencies in the dental office and a patient losing consciousness. Antibiotics are not considered one of the medications that alter a level of consciousness in a patient, but the other ones actually have can actually sedate the patient to varying degrees. When considering how to prevent a medical emergency, specifically unconsciousness in the dental office, we want to begin by taking a thorough medical history of our patient. By evaluating risk factors and dialoguing with the patient, we can hopefully uncover any undisclosed or hidden fears that our patient may have, and then offer some type of sedation or other options to reduce the risk of any emergencies in the dental office. When a patient arrives to have treatment that has been proposed, we should not find out for the first time that the patient has some type of an impaired physical status. That information should have been established at the first appointment, consultation, or examination. So we want to review their medical history, find out if there's any impaired physical statuses, anything that we need to be more alert towards. And as we begin to talk with the patient, we can do a psychological evaluation. Yes, we're not psychiatrists or psychologists, but we can find out if the patient is able to understand first what we're saying, if they are under some type of an influence with medication or whatever else, if they have undue stress, if they are overly anxious. We can find out these informations as well as we evaluate them before the procedure. Make sure to look at their ASA status. And then when we dialogue with the patient during their medical review, we can actually see both the physiological and the psychological predisposing factors that the patient may have. And that's part of our job as a dental assistant. We need to be the detective looking for information that may not be so apparent. When I prepare to talk to you about medical emergencies, I go to the go-to book of medical emergencies in the dental office that's written by Stanley Malamed. And in our material, you may hear me refer to Malamed throughout all of this material because he really is the go-to guy when we are trying to keep updated on medical emergencies and current procedures and protocols. I wanted to share with you his definition of the clinical manifestations of unconsciousness. A lot of us think that a person that is unconscious is asleep. Therefore, we can wake them up. But according to Malamed, he defines the unconscious person as one who does not respond to sensory stimulation such as shaking and shouting, and has lost their protective reflexes such as swallowing or coughing. And this is accompanied by the inability to maintain a patent or open airway. So when a patient is unconscious, their muscles relax. Their tongue is a muscle, and so when the tongue relaxes, it falls to the back of the throat. And in the dental office, if a patient is laying flat, facing up, and their tongue falls to the back of their throat, their airway is effectively closed. So they are unable at this point to maintain their own airway, which we'll talk about shortly, about maintaining the airway. So in order to recognize if a patient is unconscious, we're going to use the shake and shout method. So we're going to shake their shoulder vigorously, not enough to harm them, but enough to hopefully wake them up. We use something called the Vulcan death grip, which is illustrated by Spock in the Star Trek picture to our right. And that is basically digging our fingers into their collarbone and behind their neck. And that action causes enough painful stimulation that most people who are not literally unconscious will wake up. And the Vulcan death grip can also be considered fingertips on the sternum or pain stimulus. If you don't want to use the Vulcan death grip, you can also just tap on their sternum. And by tapping, it actually wakes a lot of people up, and I use it when I work with conscious sedation patients who are not breathing often enough, and I need them to wake up a little bit more so they can breathe more and get a better supply of oxygen. Once you have stopped the procedure on a patient that has become unconscious, the usual rule of thumb is that you place the patient into a subsupine position. The purpose being that when the patient's head is lower than the rest of their body, that's where the blood pools, and it restores consciousness by bringing blood to the brain. However, if you have a patient who is in their 3rd trimester of pregnancy, this rule does not apply. You cannot place this woman in a subsupine position. Instead, you need to turn them onto their left side and then place a pillow behind their back to hold them in that position. If you place a woman who is in her 3rd trimester into a subsupine position, you run the risk of, due to a pregnant woman's changed internal anatomy, you run the risk of having her vena cava blocked. And if you remember from anatomy, the vena cava is a huge supply of blood that leads straight into the heart. So if we are blocking that supply of blood to the heart, we are putting the patient even at a greater risk by putting them in a subsupine position. So again, we're going to roll the 3rd trimester pregnant woman onto her left side, facing the dental assistant, putting a pillow or something behind her back to support her in that position until she regains consciousness. A major factor in the prevention of loss of consciousness was the introduction of sit-down dentistry, in which the patients are treated while they lie in a supine or only slightly upright position. The supine position, meaning that the feet are elevated 10 to 15 degrees, prevents the drop in cerebral blood pressure, which means blood flow to the brain, which is the most common mechanism which predisposes a patient towards syncope or fainting. So by keeping a patient's head lowered, allowing blood to get to the brain, we actually are helping in the prevention of unconsciousness, even though that wasn't our intent when we built the chairs to be the way they are. If you have a patient who is unconscious or becomes unconscious, stop the procedure immediately. Lower the chair into the subsupine position, meaning the head is either even further below the feet than it was in the original position that the patient may have been in. So this means that the feet are now 10 to 15 inches above the patient's head. And then the patient, if this is syncope or fainting, the patient should rouse in 15 to 20 seconds. If it is not a simple case of fainting or syncope, the patient may not rouse in 15 to 20 seconds. By lowering the patient's head, again, what we are trying to do is we're trying to flood the brain with blood, which again rouses the patient from a faint. As you're sitting watching this slide, listening to this video, I want you to actually move your head a bit. I want you to lift your head as high as you can and see how easy it is to breathe. Is your breathing impaired at all? Does it feel like your airway opens more the further you lift it or less? Now tuck your chin in as close as you can to your collarbone. And then tell me, is it easy to breathe or is it harder to breathe? What's happening is we are changing the angle of our tongue and our soft palate, which is changing how patent or open our airway is. So when we have an unconscious patient who we have determined is unconscious using the technique of shake, yell, stimulate with pain with the Vulcan grip or pinching them. If they are not roused or awakened with any of those techniques, we can determine that the patient is therefore unconscious. Once we have determined the patient is unconscious, we need to begin by opening their airway. Remember, an unconscious person's tongue has relaxed and that it no longer has any specific shape. Now, in a dental chair, the patient is face up into the air, therefore their tongue is dropping into the very back of their throat and collapsing into their airway, so they cannot breathe. So we need to maintain their airway for them using the head tilt chin lift. When you are doing a head tilt chin lift, you want to lift the chin so that you could draw a straight line up and down from the chin to the ear. If you're drawing it more diagonally, you don't have the right tilt. So remember, when we moved our chin around by moving our head up and down, we changed our airway. The same could be said with how we position the patient with a head tilt chin lift. The most common errors that people make with a head tilt chin lift is by not lifting the chin enough, and therefore the patient is not getting the air they need. When you do a head tilt chin lift, you want to push back on the patient's forehead while lifting the patient's chin. Make sure that when you do the head tilt and chin lift, you are only pushing on bone and not soft tissue, which tends to, in the areas that we're pushing, it tends to push into their airway, further restricting airflow. So when we do the head tilt chin lift, we're only going to we're going to push back on their forehead bone, their frontal bone, and we're going to pull up on their chin. The other technique that we can use is a jaw thrust technique. And you would use this if the head tilt chin lift technique did not work. In most cases, the doctor is the only one who's actually been trained on a jaw thrust technique. And we use this technique if the patient's airway is somehow, if there's something in it which prevents them from still getting enough air by the head tilt chin lift. So now we need to open the airway even further, and we have to dislocate their jaw to do that. To do a jaw thrust, we're going to basically be pulling forward on the jaw, pulling it out of its socket. Again, mainly only doctors are trained for the jaw thrust technique. So we have now come to the conclusion that our patient is unconscious. We've lowered them down to a subsupine position so that the blood can rush to their brain. We've opened their airway so that we can maintain an airway for the patient that's unable to maintain their own airway. Now we're going to look, listen, and feel just like you do with CPR. We're going to look for chest rise, we're going to listen for air movement, and we're going to feel for air movement. The biggest error that a person could make is to assume that a patient whose chest is moving means that they're getting air. So a rising chest does not in fact mean that the patient is breathing. It only means that they are trying to breathe. So they may not be getting enough oxygen to maintain life. So we need to make sure that when we listen and feel, we feel the air on our face, on our hand. We have to confirm that air is actually moving. So you have to hear and feel the air movement to know that they are breathing. In the case of a partial airway obstruction, a partial airway obstruction will produce sound like a wheezing, but a full obstruction of the airway does not. The patient will not be able to move air, and they won't be able to move sound. If the patient's airway is obstructed, you need to lower the patient even more so that their head is even lower, so that that object that is in their airway goes to the upper part of their lungs and airway instead of further down where it's going to be harder to retrieve it. So we're going to lower the patient to a further subsupine position so their head is quite low. And we're going to hope that that brings whatever object is in their airway further up into their throat. And we're going to turn the patient's head. By turning the patient's head, we're also going to help keep that patent airway. And remember, patent means it's open. Then we're going to try and remove the obstruction. So in this case, it may mean that the patient has actually aspirated an object that we had in the dental office, like a crown or a rubber dam clamp or something of their own. But we're going to try and remove whatever that obstruction is, if at all possible. One thing that we have at our disposal that not everybody else has is a high-speed vacuum. So we're going to use our high-speed evacuator only if it has a rounded tip on it. And you'll see this on page 130 in your book. If you don't use one with a rounded tip, you can actually end up wounding the patient's pharynx, causing bleeding, which could then also be aspirated, which could make this situation worse. So we want to definitely only use a rounded tip HVE. Then we're going to also provide any necessary rescue breathing. Oxygen is our best. It's better than air. Syncope is a sudden loss in consciousness. There are two different types of syncope. One is called vasodepressor syncope. The other is orthostatic syncope. Vasodepressor syncope is what we all know as the common faint. You might also hear vasodepressor syncope called vasovagal syncope. In vasodepressor syncope, usually what will cause a patient to lose consciousness is indicators like stress or medical conditions that they may have that all of a sudden change their blood pressure. When I was in high school and middle school and in choir, our choir director would tell us not to lock our knees during a concert when we would be standing for up to 40 minutes. When you lock your knees for that length of time, you can actually reduce blood flow and actually lose consciousness. So this is considered a common faint. We know it as vasodepressor syncope. In orthostatic syncope, this is the patient that will faint when they're suddenly sat upright in a dental chair. So if we have the patient in a subsupine position or supine position as we do treatment, and then we sit them up into an upright position, if we don't allow them the time for the blood to recover and get to all the areas that maybe it was a little low on, because their head was lower than their feet may not have all the blood flow yet. When we sit them up, we want to give them time for everything to normalize. If this patient were to be left alone in the room while they are recovering, our office runs the risk of having a medical emergency while we're not looking. So with orthostatic syncope, what has been found is that the patient often will be moving around in the chair while they're waiting to recover, and like a woman will reach down to grab her purse and keep just falling out of the chair head first as they lose consciousness. Or if somebody is grabbing something off the counter, they may fall forward and hit their head on the countertop. So in orthostatic syncope, in instances that we want to prevent this from happening, as we sit the patient up in the chair, we want to stay by their side until they've had a chance to recover. In some cases, we know that our patient has orthostatic syncope. If this is the case, as we sit them up, we want to sit them up in stages in the chair. So we'll sit them up a little bit, let them sit there and wait for a moment, then sit them up a little bit further, let them rest there for a moment, and then maybe finally sit them up the rest of the way. Always let them rest for just a few moments. In orthostatic syncope, when a patient is to suddenly change position, it could be somebody who's getting up and out of bed after sleeping all night, could be in a dental chair after being in a supine position and being sat up. What happens is their blood pressure changes so rapidly that they just lose consciousness. So we want to decrease the chances of this happening by giving the patient the chance to recover fully. With the later warning signs of vasodepressor syncope, we might see things like pupils that are dilated in our patients. They may begin to yawn or start yawning even more than they were before. This is actually the body's way of increasing its oxygen supply by breathing in more and exhaling more. Also, by rapid deep breathing, you're also increasing your oxygen supply, and it's our body's own defense system to stop the emergency. A patient's hands and feet may feel cold as the body is bringing all of its emergency resources to the center of the body to deal with the emergency, leaving the limbs colder as the blood is not rushing to them as much as it is to their vital organs. You might also find that the patient has a lower blood pressure. We call this hypotension. Another thing that you would see is a low heart rate, which we call bradycardia. And lastly, you might see the patient may be experiencing some visual disturbances or even feel dizzy. We can look for all of these signs in our patient when we are giving treatment. Some people may find it quite surprising that men have a higher likelihood of experiencing vasodepressor syncope in the dental office than women do. Because women are more likely to express how they feel, if they're afraid of certain treatments, if something is hurting and they're not numb enough, or if they are really stressed that day, women are more inclined to tell somebody about that than men are. Men who live by the macho rule are more inclined to just hold it all back. And if you are holding back all of those feelings of fear, anxiety, and if you're experiencing pain, all of those are stressors on the body and on the mind. And remember, stress is the key ingredient to medical emergencies. So if we are not reducing that stress factor and are actually increasing it in our patients, then we may experience a vasodepressor syncope emergency with men in our office. So it's really important to educate men and women both that they should be discussing with us how they are feeling if they are experiencing any discomfort. Recognizing the signs and placing the patient in a subsupine position before they lose consciousness can actually stop the progression of the emergency. So we've learned different signs and symptoms that will lead us to understand what's happening to our patient. Are their pupils dilated? Has their respiration increased? Has their heart rate increased or decreased? Has their blood pressure increased or decreased? Are they yawning more than they used to? Look for the signs and symptoms so that you can intercede and stop the emergency instead of watching the emergency happen. Ammonia can also be administered to a patient to revive them. So while we lay our patient back in that subsupine position and maintain an airway, we can also administer ammonia to help revive our patient. Orthostatic hypotension, also called postural hypotension, is the classic syncope where the patient jumps out of the chair and plummets to the ground. And this is caused also by a plummeting blood pressure that also is falling so quickly that the patient just falls with them. So this is the person I talked about earlier, that when we sit them upright in the chair, we do it in stages. Instead of sitting them up abruptly, we do it slowly, allowing them to adjust with us. And this is also the patient that we don't leave in the chair while they are recuperating. We sit with them or stand next to them so that they don't reach over and grab their purse from the floor, or reach over to the counter or to grab the magazine and then fall out of the chair either head first or into a counter. Sometimes with orthostatic hypotension, a patient has had a previous episode, and so hopefully they will put that information in their chart. But everybody has a first time with orthostatic hypotension, and it could be in your dental chair, so watch and be aware. The following factors contribute to postural hypotension, also called orthostatic hypotension. When a patient is laid back in a subsupine or recumbent position for any length of time, we increase their chances of having an orthostatic event. Physical exhaustion and hunger can also increase the chances of having an orthostatic event. If a patient has inadequate postural reflex, which is one of the things that happens when somebody locks their knees for any length of time and can pass out, they have an increased chance of orthostatic hypotension. And also the incidences can increase with age. In the next slide, I have a funny little story that I found out of Canada of a troop of soldiers who were supposed to be guarding the castle but kept fainting on the job because of inadequate postural reflex due to locking their knees. I think it's funny. When reviewing the medical history, if you notice that the patient has recorded that they have Addison's disease, you should be aware that the patient has been most likely receiving a medication that lowers their blood pressure. So in the case of a patient with Addison's disease, if they are anxious and the doctor is inclined to give them nitrous oxide or Valium, you need to make the doctor aware of the presence of Addison's disease, because the use of nitrous or Valium on an Addisonian can actually cause their blood pressure to drop too low, putting the patient in danger and at risk.